Let's start with some welcome and introductions. My name is Zoe Robbins, and I am the current chair of the board here. I guess we're council rather. Right. Yeah, we're a council. And I am a psychiatric nurse practitioner. I teach in the psychiatric doctoral nurse practitioner program at the College of Nursing and see some patients as well. I do part-time telehealth, seeing patients at Four Corners Community Behavioral Health in Price, and otherwise manage a few clinicians around the valley that I'm always working to get on more telehealth. And I think I'll pass to through our table here live, and then I'll ask Matt to hit the people online because I don't have a screen. Go ahead, Linda.
Hi, I'm Linda Edelman. I'm Linda Edelman. I'm a professor in the College of Nursing at the University of Utah, and am working a lot with HRSA workforce development grants in long-term services and support and primary care, including a number of rural Utah clinics. Glad to be here.
There we go. Hi, this is Anthony Torres with the Utah Navajo Health System. I work as a special projects manager in their information technology department.
And I'm Cesarini, and I'm an associate director with UETN, specifically focusing on our healthcare customers.
Jennifer Lloyd, Deputy Director at the Association for Utah Community Health, or OUCH. I work with Utah's 14 community health center organizations around the state.
Stephen Salter, IT Manager at Gunnison Valley Hospital.
And Matt McCullough, Director of Telehealth Services with UETN and the Principal Investigator for the Northwest Regional Telehealth Resource Center.
Hello, Rich Finlinson. I am Director of Communication for UETN.
Okay, I'll go around and call out the names of those that are online. So I'm just going to go top to bottom. Let's see, Mike Shooping.
Good morning, everybody. I'm Mike Shooping. I'm the Director of Administration here at UETN, and I run the procurement staff. Thanks for having me.
Thanks, Mike. Brian Crowther.
I'm Brian Crowther. I work for UETN. I'm the systems administrator, and I help Mars and Matt out as much as I can.
Thanks, Brian. Susan.
Good morning, everybody. I am the Public Relations and Communication Manager for UETN.
Thanks, Susan. And Eric.
Eric Packer, Administrator at Cedar City Hospital.
Great, thanks, Eric. Let's see, we've got Denise with us here. Denise is waving her hand. Nikki.
Good morning, I'm Nikki Parasho, the Program Director for the NRTRC.
Thanks, Nikki. And Jolene.
Good morning, everyone. I'm Jolene Johnson. I'm the Program Manager of the NRTRC.
And Casey.
Morning, everybody. My name is Casey Shakespeare. I'm the Vice Chair of the group, and I work with Southern Utah AHEC and Southern Utah Area Health Education Center, whatever we're calling ourselves today.
Right. Thanks, Casey. Mike Foster.
Mike Foster. I'm the Director of IT at Moab Regional Hospital.
And Joanne, you don't have a microphone, but welcome, Joanne. Okay, did I miss anybody? Everybody here. Okay.
They got me.
We got Denise.
And Denise.
And Tim. Thank you, Tim, for helping us with the technology today.
Our first order of business today, our very important order of business, we've been waiting for a quorum, is the approval of minutes for the following meetings: February 3rd, April 7th, June 2nd, and August 4th. all of you should have received all of those minutes previously. Could I get a motion to pass?
I'll make a motion. Set the minutes.
Thank you, Stephen. And a second, please.
I second.
Thanks, Jennifer. Okay, so we have formally approved minutes for. Oh, yes, sorry. All in favor, say aye, please. Aye.
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 Thank you. So we're approved for the minutes and we'll catch up on December's in October's in December, right? Yeah, okay. Next, we're proud and excited to show a video of the Deborah Lamarche Telehealth Excellence Award. Matt went to the source of the award, which was Dr. Todd Vento at Intermountain Healthcare, and we'll show you the video right now. I haven't seen it yet.
So I'm from the Utah Education and Telehealth Network, and we're here today to actually present an award to you.
Oh, thank you very much.
And we've kept it. Your good colleagues here have kept it a surprise.
They did. They did just that.
So this is called the Deborah Lamarche Telehealth Excellence Award. This is the third year that we've done the award, and it's to recognize an individual or an organization in the state of Utah who's done outstanding work in the field of telehealth. And so Adam here nominated you for the award a few months ago. I won't read all of this, but let me just kind of read a little bit of what Adam said. He said, Dr. Vento has been a tireless champion for telehealth for years. Never has his influence been more needed and seen than during the COVID-19 pandemic. Todd's contribution to one of the leading telehealth operations in the country has been substantial, and we think he's well deserving of this award.
Thank you, Adam.
So, yeah, congratulations.
Thank you very much.
So this is called the Flame Award, and we really like the design because it represents passion, of the flame that burns within you to do great work in telehealth and in medicine. So this is the same award that we've used for the last few years. It says Deborah Lamarche Telehealth Excellence Award presented to Dr. Todd J. Vento.
The first thing I thought of when I was getting an award was that I think that award could go to anyone on our team. I really mean that. We do so many people do so many things. We have weekly huddles and weekly leadership huddles, and we have a group that really enjoys working with each other. We always have a lot of fun while we're getting a lot of serious, important things done. And so, I mean, I am honored, but I think that just reflects the work. My work is just reflecting what we do as a team.
Dr. Vento has for a long time been a significant leader for us. His ideas are innovative. He's consistently pushing us to think about new ways to reach patients and be able to broadly spread expertise that rural communities need desperately.
It's great working with Dr. Vento. It's fun. He's got a ton of energy and he loves infectious disease. And I call him just last week, for example, I was ICU attending at the bedside and he was the infectious disease doc taking care of my patients. And we had some very complex patients that I had to call him about. And he provided tele-infectious disease coverage. And he's done that for me many times, whether I'm practicing critical care at the bedside. Many times I've had occasion to rely on Dr. Vento, and it's always a pleasure.
During the pandemic, we would not have been as successful as an organization in delivering the kind of care that we did during the pandemic without him. And so that was an easy call when we saw the award and what it entailed and what it was for, that Todd was a natural fit for that, just because he's been so effective for us.
I think I see a lot of similarities in how at Utah people come together and just want to get the mission accomplished. And knowing that they're all 100% in to make a difference, whether it's to save a life at the moment or to put programs in place to get care and expertise to individuals in rural communities, small critical access hospitals who need help.
Really nice. Very nice. Thank you.
I just wanted to mention a few things. We were gonna try to live stream that presentation during the advisory council meeting, but couldn't find a date with Dr. Vento's clinical work.
Not surprised.
And so we had to surprise him. And they told him that he had a meeting with a vendor. So I don't know how excited he was about going into that meeting, but when I showed up, it was kind of interesting. Dr. Vento is a formal colonel in the military. And I got out of my car and walked in, and he was right behind me coming into the building for another meeting. And I had this big black box with me, and the award was in it. He didn't know who I was or why I was there, but after I presented the award to him, he told me that he thought I was pretty suspicious looking
with your big black
as
box.
I walked into the building with a big black box. And
he was keeping an eye on you.
Maybe he thought you were the vendor.
Yeah, maybe. He was very gracious. He was very surprised. His whole team kept it a secret from him. And as you saw, he was very willing to give the credit to his whole team for what they did.
Yeah.
So we had 9 total nominations for the award this year. And we asked a few of you members of our advisory council to review and score the nominations. I did want to ask if any of you that reviewed or scored the nominations, if you had any comments or thoughts about that opportunity, because I think we'll do that again next year and have members of the advisory council participate in scoring and selecting a winner. Did anybody have any thoughts about that process, or?
Who here did it? You did.
I thought it was pretty easy. I mean,
Turn the microphone on right there.
I thought the process was easy. I mean, and it gave you a chance to look at the nomination forms. I mean, it was a nice electronic form to use.
Mm-hmm. Yeah, the nominations were all great. I mean, any one of the 9 could have easily won the award. But it was neat, kind of coming out of this pandemic to see somebody who had such an impact throughout the pandemic in infectious disease. They said that basically every COVID patient in an Intermountain facility received a virtual rounding every day because of the telehealth technology and setup that they had. So.
And do they use the walkable carts? That vendor was at the NRTRC, those incredible walkable telehealth carts.
Either the carts or they have screens with cameras in the rooms.
Yeah.
So they can basically beam the physician right into the room.
Yeah.
On that screen.
There's the head of psychiatry for all the state prisons in California is really into telehealth. He came and spoke to the state. I can't remember his name right now. Anyway, that's his dream too, is to have screens in every jail cell. Right. So you can do telehealth visits right into the cell.
Yeah. Well, it was a great experience and just fun to pause kind of in the middle of the day and recognize somebody for the great work that they do. He was, again, very gracious and thrilled to get the award.
I
so
bet.
We'll open nominations again sometime next spring and do it again.
Cool.
So I did want to say thank you again to those of you that helped review nominations and help us select a winner.
That was nice. Thanks. So Matt's going to stay on with us for a little while. He is going to show us the Utah Telehealth Claims Dashboard that is still in the works, but close to finish.
It's up.
It's up.
It's
oh,
live.
It is.
Yep.
It is live.
It's live.
Okay, let's look at it.
So maybe the best thing, okay, Tim, I lied to you, but I'm gonna share my screen now if that's okay. Let's see, I probably just need to push this. especially for those of you that are joining us virtually, I'm going to share my screen. I did hand out a hard copy paper executive summary of the. Okay. Yeah, there we go. Okay, so if you can see everybody online, you can see my screen, okay? All right. So right from the homepage of the website, if you go to About and come down to Dashboards, we have a number of different data dashboards, but the top one is called Telehealth Claims. It is live now. All this data has been published for a few months. And what you have in front of you, if you're here, is just an executive summary write-up of some of the trends and key findings from the data. So let me just introduce it quickly. Basically, all the data we receive a monthly update from the Utah Department of Health and Human Services from the All Payer Claims database. And they aggregate all of the claims together for us to make it easy to create all these charts and graphs. Within the website and on this executive summary, you have a link to a methodology document that basically says the CPT codes that were used to pull the data. There's lots of different ways to identify a specific medical claim as having been done over telehealth. So we wanted to make it very clear the modifiers, the codes, and how we identified those claims. And so that's one resource you can look at for understanding how the data was pulled. Let me just hit a few highlights. And again, it's publicly available if you want to use it for research or policy recommendations, any of the work that you're doing, you're welcome to. So this first chart basically shows the trend. The data starts in January of 2019. And basically all through 2019, we had about an average of 2,000 telehealth claims per month in the state of Utah. The peak was April of 2020. There were 163,000 telehealth claims. And percentage-wise, I think that was about 43% of all medical claims were telehealth. So huge spike in April. And then you can see from the trend line, it's basically decreased fairly consistently. And I would say has kind of leveled off since summer of 2021 to today. We're still at about 67,000 telehealth claims a month, which is about almost 13%. So in the executive summary, we mentioned just how much growth that actually is. From pre-pandemic to today, it's a 3,770% increase, which is incredible. And the next one, actually, I could go through. Well, I think for those online too, I'm going to go down the website view here. So the next one that I want to point out that I think will be really important as we go forward is the average allowed payment amount. So let me point out a few places here. In January of 2019, there was a big difference in the payment rate for in-office visits and telehealth visits.
Just remove that reminder in the bottom right corner of your screen.
Oh, got it. Thank you. So average payment for a telehealth visit was $54 compared to $106 for an in-office visit. You can see as 2019 went along, that started to change. And really, in April and May of 2020, those payment rates were almost equal. They were off by just a few dollars. That has stayed Oh, I love it when you do that. That has stayed pretty consistent up until today, where the average payment rate is just off by a few dollars. So our goal with this project, one of our goals is to continue to collect data for at least a year after the official end of the public health emergency. So that hasn't happened yet. It may even be extended for another 90 days. But what we want to look at in this chart is, do insurers, payers start lowering the payment rate for telehealth visits after these waivers expire and the public health emergency ends. Let me pause. Feel free to ask questions. I don't need to talk too much if anybody has a question.
I do have a question. The increase in reimbursement was related to people understanding better how to bill for it, or because insurance claims changed, the billing rate changed as the pandemic hit, which...
Yeah, it was primarily because of the changes at the federal level with Medicare that they started paying the same rate.
Yeah.
And so insurers followed suit and they started paying the same rate.
That quickly. It just happened almost immediately.
Yep.
Okay, thanks.
Yeah, I think if anything, it confused more people on how to actually bill for the service.
Yeah.
I don't know that they got
figured
better
out,
at it
yeah.
or improved it. It took some time for people to figure out how to submit a telehealth claim and get paid
Is there
for
a
it.
chance that equal payment will continue even after the emergency ends?
So that's a really good question. Hopefully everybody online heard that. The question was, is there a chance that the equal payment will stay the same even after the public health emergency ends? So I can take that a couple of ways. In some states, they have developed payment parity laws. And so in those states, the answer is yes. In Utah, we don't have payment parity. So what I've heard is that it's really up to the payer. Some payers have said that they will pay at 90% of an in-person rate consistently.
Who said that?
I don't know if I should name names.
Okay.
But how does that work with Medicare not being a state program?
Yeah, so Medicare, it's really going to depend on the service and the provider. So they're trying to keep some things in place, such as being able to do a telehealth visit anywhere, right? In the home, in an urban area, in a rural area. So I think time will tell which of these waivers stay in place and how that impacts payment. But that, like I said, that's one of the main reasons we wanted this data and this chart in particular, so that over time we can see what's happening and hopefully inform, policy, the legislature on what's happening with payment. The assumption is as payment starts to decrease for a telehealth visit, claims will probably follow, right? That's kind of how it's always gone. As payment goes, telehealth claims seem to go. But it is, for now, holding steady at, 12% of all claims. So that's good news. Any questions from anybody online? We don't want to exclude those of you joining us virtually. Feel free to unmute and ask a question. So I won't take too much time on the others. We did compare claims by male versus female very consistently from before the pandemic to after. Females seem to like telehealth more, 65 to 34%. That hasn't changed much at all. We also looked at it by age group.
So I noticed on the age group, almost everybody in this room would be included because it only goes up to 50.
So that the legend scrolls.
Oh, because I
Sorry.
was just looking at the print and I
Okay.
was like, whoa.
Oh, it cut it off on the print. Good point. I didn't catch that.
I'm betting
So-
50 plus makes a few Yeah.
Yeah, so online, the legend didn't quite fit, so it will scroll, but in the printed copy, it ends at 49 years old. That's a good point. I think on this one, I'll just point out that, very consistently, even before the pandemic, but primarily since then, the highest users of telehealth have been really the age group of 25 to 39 years old. So it's that younger age group that's using it primarily. There's a chart here that looks at it by local health department. And because of the differences in population sizes, we normalize the data by population, the 2020 population. If we didn't do that, basically the largest counties or health department areas such as Salt Lake, Davis County, Utah County, or the highest users. But when we normalize it by population, Summit County, so the Park City area, actually has the highest percentage of telehealth claims per population.
Hey, Matt, just to let you know, your screen sharing went off.
Oh, did that take too long?
No, for some reason it dropped, so you would just have to restart the ClickShare app.
Okay. If it timed out on me because I was too wordy. It's trying. I think we'll keep trying to reconnect here, but I'll keep going. If you want, you could go to the utn.org website and pull up the dashboard and follow along that way. For some reason, my screen sharing isn't working again at the moment. Okay, so percent of claims by local health department. I mentioned highest users, Summit County, still Davis County and Salt Lake. Also, we're in the top 3 or 4. Let's see, we looked at urban, rural, and frontier areas. This chart basically just shows the total number of claims, which again is a little misleading because it needs to be normalized by the population in those areas. In the printed chart, there is a graph that actually shows the percent of claims normalized by population. All of the areas, urban, rural, and frontier, saw very similar growth in the pattern of telehealth use. I think this one's also been very interesting to watch as the trend has changed. This shows the percent of telehealth claims as classified as behavioral health versus not behavioral health. This one's challenging because behavioral health codes are difficult to identify in claims data. There's a number of different ways to identify the claims. The methodology document we developed clearly explains the codes and why we pulled the data this way. But you can see the growth in behavioral health, over time to now in June of 2020, behavioral health is accounting for 67% of all telehealth claims. So I think, that trend looks like it's gonna continue that direction, where behavioral health is just a very natural fit and a good modality for utilizing telehealth. So we can tell us a lot more about that.
Yeah,
I think.
well, it does make me think that mental health specifically is an area of healthcare that people pay out of pocket often. And it would be interesting to know how many of these out of pocket private payer clinicians are using telehealth. I know from my colleagues that it's a lot. Yeah, I would guess that you would add on some large percentage numbers just from cash pay folks.
That's a good point. The last one I'll mention here at the bottom of the page is telehealth claims by specialty type. I think maybe just point out that, family medicine was high on the list, but behavioral health was the top. So this includes a number of things like social workers. Let's see, we have there's a few different categories of behavioral health providers that were at the top of the list. But one of the things that's been requested that we do want to do is break down the average allowed payment amount by specialty. So that's something we're working on. We've also made a request to the all payer claims database team to have another chart showing telehealth claim usage by race and ethnicity. We're obviously very interested in the digital divide and the use of telehealth by different race and ethnicity categories.
Did you, I didn't see it, I don't think you did, specify substance use disorder claims?
No, we have not.
That would be
identified them specifically.
Yeah, that would be another interesting one, because like a SUD-C, the people that do a lot of the substance use assessments wouldn't be captured in this. And I don't know if they're even able to make claims, but yeah, anyway, substance use disorder claims would be really interesting, I think.
Yeah, great. So that's kind of my overview of the dashboard. We do update the data every month. Is there anything that anybody suggestions, I guess, anything that you see that's missing or that you'd like to see broken down further?
I think it would be interesting to look at the specialty type claims by urban and rural to see how that changes. And then when I look at the health department data, it also makes me think about social determinants of health, with Summit being so much higher. Is that because a higher percentage of the population is insured?
Or there's just an office that's really, really invested, and so
right.
they curbed the.
I think social determinants of health and digital literacy, access to high-speed internet, access to devices in the home.
You've got your Z codes, right? Your Z codes are your social determinant of health codes. Unfortunately, a lot of people don't use them because they're not really, or they're minimally reimbursable, but they are designed to capture that. So you could start with your Z codes. It wouldn't be a real true sample, but it might be a place to start.
Or we could just do ecological data and by what we know from census data from those areas too. So a description of the population, not necessarily the patients.
Okay. Great. Good feedback. Any other thoughts, comments? Anybody online? All I can see is Mike Shooping. So Mike, it's up to you to make a comment here. Okay. Yeah, let me know if things come up. I was at a community health center the other day, and the question was brought up, if we're going to do telehealth, we'd like to know what population we should market to, who's using telehealth the most. And at the time, the dashboard wasn't live, so I didn't know the answer. I probably could have guessed somewhat, but it's nice to actually be able to see this data and answer some questions like that. Payment and demographics of who's using telehealth the most.
Okay, thank you for that, Matt. Our next item on the agenda is a review of the NRTRC Annual Conference by Nikki Perisha. I will just say I attended and I thought it was really well done. I made some great connections, saw some incredible speakers. I thought it was a really well done conference, and I think I've already said that to Nikki, but Nikki, tell us more how to go.
Thanks, Zoe. I appreciate that. It was great to see you there in person. And, you know, I think what you just shared echoed the thoughts and communication that were verbalized during the event itself. We haven't gotten the surveys completed yet. I think we had about 40 people that have completed the post-conference survey. So we're really excited to sort through and see what people's feedback was. But really, it was the success of the conference, I think, was just a result of the great teamwork between the NRTRC and UETN, along with the conference events management, Megan Webb, leading the conference, the details piece. So I am just going to highlight a couple of the takeaways from the keynote speakers today. The conference itself was a 2.5-day event. We started out with a grant writing workshop that was put on by NOSOR. Terrell Ising, we were there, who's now retired. She did it as a consultant role. And that was just amazing feedback. She did an excellent job. She historically had offered, I think it's like an 8-week course on grant writing, and she condensed it into a 3.5-hour session. So it was fast and furious, but really provided the attendees with a lot of tools and knowledge, and also questions to ask for writing a successful grant proposal. So that started out the event. And then our opening keynote speaker, her name is Adrienne Boise, and she's a neurologist. She was historically with Cleveland Clinic, but she now currently is the CMO of Qualtrics. Her take on telehealth is, it's all about relating to the human, treating your patient as a human, and creating those relationships and trust. She shared a personal story, I think, which really helped to draw the attendees in. Her husband's a neurosurgeon, she's a neurologist, and she has 2 young children, one of them that has a medical condition. And she shared what it involved for her and her husband to get her child to a medical appointment, and the trials and tribulations that occur, and then also kind of a cost on what that 4-hour event was. And I think that really, hits home on why and how telehealth is such a viable access of care for some patients and some diagnoses. And she really stressed that, the work that clinicians and providers and administrators do is about telemedicine, but it's really rooted in how we care for people, and how we convey emotion with technology and deliver on caring for people as people. So that's how we started out the conference. And one of her closing points was, unless 20% of what you do is meaningful, you are at risk for burnout. So, in this time, I think clinicians, providers, and healthcare administrators can relate to that. So that was a great start. The closing out of the first day, we had an overview on telehealth policy from leading subject matter experts. We had May Kwong with the Center for Connected Health Policy. We also had Ben Steinhoffel from CTEL, and then also Kyle Zebley, who's the Senior Vice President of Public Policy at the American Telemedicine Association, or the ATA. So those 3 took the stage, and they were moderated by Dr. Jim Bush, who's on the NRTRC advisory board for the state of Wyoming and is also the state Medicaid director. And he's been a big proponent of telehealth for a long time. And basically the takeaways is that the telehealth policy that defined and restricted telehealth to rural areas within 4 walls of a provider's office was progressive in 1997, but it is wildly outdated in 2022. So that was an interesting piece. They covered a lot about the physician fee schedule that will be released next month, and what that might look like for telehealth. They didn't have anything definitive, but just to keep our eyes open. Also talked a little bit about the PHE and how at this point, it looks like the public health emergency that allows these telehealth waivers will be extended through January. And then with the Omnibus Act, an additional 6 months. So we're looking at the telehealth flexibilities being in place through probably June-ish of 2023, unless something happens in Congress before then. You know, a lot of discussion on how the data, they're hoping that the data shows that enhanced access to care for home health services should remain in place after the PHE expires. And then something interesting too, that there are misconceptions on originating site restrictions, and that telehealth is cost increasing, along with those fears of fraud and abuse related to telehealth. So really encouraging that a lot of education needs to occur to educate people that is a misconception and that's not true. They emphasize that what we can do, well, not me with the NRTRC, but anybody else that's not federally funded, to engage with your state representatives and share data with them on cost and utilization. So the Utah all-payer claims data, that data is so valuable to help the congressional leaders, legislators know and learn that the telehealth landscape, what that looks like in their state. And then also pressure and support the policymakers to ensure that the extended telehealth benefits become permanent. So that was, those were kind of their takeaways. They really encouraged people working in telehealth to continuously monitor and view the Center for Connected Health Policies website, because they have that comprehensive compilation of state-specific telehealth policies, including information on state-specific reimbursement for live video, audio only, store and forward, RPM, and then communication-based technologies. So they really emphasize that site as a credible resource, and also that licensure rule of thumb, that if a provider is providing telehealth services to a patient, that provider needs to be licensed in that state where the patient resides. Day 2, we started out with Dr. Ashby Wolf she's the Regional Chief Medical Officer for CMS, and she joined us virtually. And she updated us on a lot of what was happening in CMS, their national quality strategy. She provided a lot of resources, but then, talking about telehealth, she just kind of reiterated the public health emergency that I reviewed previously with the panel. And what she walked away with is that CMS is looking for suggestions around telehealth and virtual care delivery. And she strongly encouraged people and providers specifically to submit ideas and thoughts through CMS. They had just recently released a request for information. And I'll put that link in the chat box after I'm done with my updates, because really they're seeking the public input on accessing healthcare and related challenges. Understanding providers' experiences, I think that's the biggest thing, is they really want to hear from providers and what's working with telehealth, what challenges they're finding with telehealth, patients, the challenges patients are running into, to help create law that makes sense. And to advance health equity, that was a huge focus of CMS moving forward. And then also accessing the impact of these waivers and flexibilities that have been provided in a response to the COVID-19 public health emergency. So it was great. And I mean, I could take all 3 hours to give updates, but I'm just trying to summarize some of the greatest takeaways. We had Chris.
Hey, Nikki.
Yeah.
Sorry, this is Matt. I wanted to give an example at the end of that session about CMS and policy. There was a question that was brought up. This is the kind of thing that can impact all of you, and I thought it'd be worth sharing. The question that was brought up was, when a provider submits a claim, they have to list the address of the clinic or hospital where they're located. And more providers are being hired to work 100% remotely to only do telehealth. And so healthcare systems and providers are worried that they're going to have to list their home address on the claim. And the answer that CMS gave was, if the provider works from home, seldomly, randomly, maybe one day a week, they can list the address of the clinic or hospital. But if they work from home completely, that they will need to list their home address on the claim. And so that's concerning. And they basically said that there is or there will be an information request that CMS will put out for comments. And if you're concerned about that, to submit comments and have that be addressed by CMS. But I thought that was a really good question and kind of got down into the weeds of why we had her present and talk about telehealth policy at the federal level.
Yeah, thank you for sharing that. There was a lot of great engagement from providers following that session with asking her questions. And it was great to have her there virtually. Wrapping up that day was Christy Henderson. She's the Senior Vice President and CEO at Optum Everycare. Christy spoke at the NRTRC about 10 years ago, back when she's a nurse practitioner, and she started the emergency care, virtual care at University of Mississippi. And she really was all about, again, the human connection of what we do with telehealth. And, always think big, start small, move fast, look at the data, and then also building telehealth from the consumer's eyes. How can we do that in telehealth and healthcare? Very similar to what Adrian or Dr. Boise spoke to, is for telehealth to be successful, it needs to work for the patient and the provider as well. So aim for near immediate access to a provider, and really just know how your patients are touching your system, know how they're getting in and out of your telehealth visits, some of the challenges they might have, what they can and can't do, really get into the flow of what works for the patient. The next highlight I want to touch on is, and if anybody has any questions, feel free to raise your hand virtually or just jump in if you're in the room.
Well, Nikki, I was going to say the woman you're speaking of, the nurse practitioner, what was her name?
Christy Henderson.
Yeah, Christy was great, super approachable. And then you had the two other nurses. And at one point in one of the breakouts, I think we were a room full of exclusively nurses. And it was really nice talk and nice conversation, because I think that what, of course, you see in telehealth, just like in any area of medicine, is people are having different experiences depending on what role they're playing. And it was really nice to have the nurses there and the nurse input, and nurses that have been nurses in the patient sense, but then maybe have moved into administration, or as Christy, had gone and worked for payers and insurance companies. And I really enjoyed hearing the nurses speak.
Thanks, Zoe. Yeah, that's her nursing background is, when I first saw her 10 years ago at the NRTRC, she drove me to want to, improve telehealth, and it just ignited that passion within me. And so having her as one of our keynotes was just, that was just such a success for me, because she touches people, and her background is so significant with telehealth, and she just makes change. She drives change. She's really, truly a hero in my eyes. So I appreciate that feedback, and having the nursing perspective there too is so interesting, because it brings it back to the patient, right? Sometimes in telehealth, and when we're looking at workflows and plans, you kind of forget about that patient, and that's really the outcome that you're looking for, is a success and getting the patient the care that they need. So I appreciate that. Next, we actually had Anthony Torres. He had Crossing the Digital Divide, and he spoke really about the challenges and successes in implementing a project to bring broadband connectivity through microwave-based technology. to address the lack of broadband on tribal lands in Utah. And so, I always love hearing Anthony speak and was so grateful that he was there. Some of the key takeaways is that, that the technical challenges and the financial challenges weren't the hardest part of the project, that the regulatory constraints were. And I think that was a big aha moment for the people in the room, especially with the slides that Anthony had shared and the images and the pictures of building microwave and getting access and fiber to these rural tribal lands that are rocky and inaccessible. So those pictures, I mean, just looking around the room and seeing people's like shocked expressions and head nods was really affirming. A couple other things that Anthony said is that if you live on tribal lands or provide telecommunications to people on tribal lands, you really need to evaluate and see what the satisfaction and what the level of what kind of access they actually are receiving, and then what the root cause is, and how to make those better. So again, there was a little discussion around regulatory issues being kind of the challenge and the barrier. But they're working hard to make improvements, and grateful to have Anthony at the lead for that. And then the final session was actually closing by Tim Lovell with Intermountain Health. He's their Connect Care operations director. And it resonated to see the award for Dr. Bento this morning and how Intermountain really is kind of driving telehealth and change and success. And he shared 8 principles of success in building a virtual practice. So the first was make telehealth a strategic priority. Number 2, be what consumers want. Number 3, disrupt without abandoning values. Number 4, form a high-performing team. 5, promote your service. 6, deliver on the promise. 7, prove your value. And 8, continually improve and disrupt. So really, throughout his presentation, there was a constant theme about the importance of capturing patient stories to change the ways in which we practice healthcare and how to engage patients with us. So the theme for our conference this year was innovation in telehealth. And I think what the consistent takeaway from all of our keynotes was how important engaging with that relationship is, or the relationship with your patient is, and engaging them in their care and creating trust with them, especially for telehealth. Because with telehealth, you don't have that in-person thing. I mean, that the touch, the empathy of feeling together. And so like even watching you all in the room before the meeting started, you could tell somebody would place a arm on a shoulder, or just the body language of being together and warm. So that's really important. For those of you all that registered for the conference, you'll be able to access the recordings for the keynotes and all of the concurrent sessions. And if you didn't, they will be posted in December on the NRTRC's YouTube page. So we'll be sending information out in our December newsletter when those go live. And I think that's it. The other piece, the other little thing I wanted to share is we had a lot of great sponsors. We had, I think, 21 exhibitors and sponsors, vendors. And in discussion with them, the smaller, more intimate conference space was really successful for them, because they got to talk to the attendees that were actually in the field and running the telehealth services, and interact and learn what their needs are and hear stories and takeaways. So I'm going to pause there, and I'm just going to see, Zoe, thank you for sharing. If Anthony or any of my colleagues that were there, Jolene or Matt, have anything to share.
I don't have anything to share. I was just going to say thanks for those of you that did attend. And I did just note in the chat that so far in talking with some of the attendees, Anthony's presentation has received a lot of really great feedback. We always love having him talk. So thank you so much, Anthony.
Thank you. One of the things that I wanted to mention is that one of the things that I learned is I'd always viewed that it was simply a matter of connecting our providers with the patients at home. And one of the things that had never even occurred to me is the whole idea that sometimes the home is not a safe place for the patient to be. And so I really like I apologize, I forget the name, but there was one of the talks talked about using space in the libraries for that, just anything that would be what I would call a third location. Because again, it literally had not even crossed my mind that that was a possibility. UNHS has been working on a project to expand our microwave connections, again, microwave, just because that's our only option at the moment, out to the chapter house locations as well. So, when you think of the library locations, and I realize there are some efforts to get some of the chapter house locations set up as a library. So I think there's probably some good compatibility with that. But if we can provide the infrastructure out to the chapter house, and if they can use that library for those, then you probably would have a good opportunity to use those as that, I'll call that neutral third party or that third location. So that was pretty enlightening for me.
Thanks for sharing, Anthony. Yeah, I think we're calling those access points. So outside of the home and outside of like a brick and mortar clinic, access points. And Jillian is actually kind of working on a project to discuss that and learn more and put together kind of some information. And I think we're going to have a webinar, Anthony. I'll make sure that you'll get this with the University of Wyoming and bring some librarians on that are actually doing these access points in their libraries as a telehealth origination site for patients. So glad you had that takeaway. And I also just want to mention, it was great to have Susan and Wrangler there taking pictures and kind of recording all of the interactions and the speakers. And we're really looking forward to getting those images and sharing them in our upcoming newsletters and having them for marketing for next year's purposes. So if there aren't any more questions, thank you for letting me share, and thanks for those that attended.
I just want to say Wrangler was a big help. Laying around all his 4 paws, it was very helpful.
I was at City Hall 2 nights ago, commenting on something in my city, and we have a beautiful brand new City Hall. And I looked around and thought, oh my gosh, it's so quiet. The rooms are so well mic'd, that everything, that City Halls are another great place. You could have a night, where people could come and do a telehealth appointment every kind of 15 minutes. Maybe there's even a nurse there doing vital signs. I mean, you start to think about the possibilities, and it feels like there is just still so much more we will do.
Also senior centers in a lot of the smaller towns that got all that funding for those beautiful buildings, and they're well equipped, internet broadband wise.
Yeah. And for some, because I do telehealth into a rural mental health clinic, I hear about the stigma of seeing my car being seen in front of Four Corners. Everyone in town knows what Four Corners is, but are you at the city hall or the high school or the senior center? There's a little less knowledge around what's happening in there. Might be helpful for stigma. Okay.
I just want to pause for a second. Thank you, Nikki, for summarizing the conference. A lot of great lessons learned. So before we go on to the next piece on the agenda with some sharing from advisory council members, I wanted to review real quick. Let me share my screen. Find the right one. Okay. I have my mute on. Hello? Hello? Okay.
That's simply the phone.
How about that? That should be better. Okay. Those of you online, can you hear me fine?
Yeah, sounding good here.
Okay, sorry about that. Commercial break.
No, not good.
Hey, that
Your
looks cool.
video's going into eternal mode though.
In my Zoom.
I can just leave it. There we go. So I'm sharing my screen. Okay, sorry about that, everybody. Before we have some of our council members share their feedback and thoughts, I wanted to review this. This is taken from the statute that actually created UETN and the advisory council. I thought it would be good to review, especially for those of you who are newer on the advisory council. I've tried over the last few years to make these advisory council meetings educational for you, so it's not just time listening to what we're doing, but helping us all stay up to date on what's happening in the telehealth world, both federally and within Utah. So that's why I wanted Nikki to cover some of the lessons learned at the conference, and I wanted to talk about the data. But I think this next kind of half of this retreat today is to talk about Utah. How do we move forward? How do we progress? How do we help telehealth be implemented? And what are the barriers to doing that? So let me just cover this real quickly. This says that the council shall advise and make recommendations on telehealth service issues to the board, meaning the UETN board, and other state entities. The council shall advise and make recommendations on telehealth related patient privacy to the board, promote collaborative efforts to establish technical compatibility, uniform policies and privacy features to meet legal, financial, commercial, and other societal requirements. And I've bolded the letter D because I think that's what we really want to focus on today. The council shall identify, address, and seek to resolve the legal, ethical, regulatory, financial, medical, and technological issues that may serve as barriers to telehealth service. And then E, explore and encourage the development of telehealth as a means of reducing healthcare costs and increasing healthcare quality and access, with emphasis on assisting rural healthcare providers and special populations with access to or development of electronic medical records. And finally, to seek public input on telehealth issues. So you may not have seen that before, but I thought it'd be good to review. That's really the purpose of the advisory council. And so I think understanding both what we're doing internally at UETN, which I'll cover a bit more at the end of the meeting, some of our current priorities and projects, but also these items, the barriers and recommendations that we can make to the board is why we're here. So I think in the agenda, I have Jennifer Lloyd and Zoe going first, and then we'll take a 10-minute break or so and come back and have a few more share. So
Can Jennifer go first?
Yeah, if she's willing to.
Yeah.
Okay.
So first I want to share a telehealth success that we've learned about recently, and it was featured in Medical Economics. Green River Medical Center had patients come in, and if somebody had an elevated blood pressure twice, they would offer them a blood pressure monitor to use at home for 2 weeks. And then they would ask them to, get their, measure their blood pressure and then periodically get it checked. And if the time they were at home, they noticed there were no hypertensive measurements, they would call these people having white coat hypertension. And this was a big deal in Green River, because everyone needs to know if they have high blood pressure or not. But a lot of the people there are drivers, like truck drivers, and if they have high blood pressure, they lose their job. So this study using remote patient monitoring equipment, which you hear about it from time to time, but you don't hear as much. This seemed like a really targeted, effective way to assess white coat hypertension, which you obviously can't do in a doctor's office because that's where the problem is. So I will send the link to Denise. I mean, it's cool. It was very simple. And again, in a community where a lot of people rely on having that, CDL, it matters. When Matt asked me about this, I pulled together some notes so I didn't forget anything, but I'm sure I will. The legal and regulatory barriers. UTN has been a really good voice. We've had Utah Medicaid come to meetings, and I think particularly through the pandemic, they quickly recognized, hey, we need to cover telehealth. And they've been I know from the health center's perspective, they've been pretty easy to work with for Medicaid. The HRSA, which is the other group that the health centers have to work with, has also provided some flexibility with regards to telehealth coverage. It's not considered a separate category of service. The current barrier we're facing, and I think everyone else is, Matt's addressed it, it's like the giant elephant in the room, is what happens after the public health emergency declaration ends. We've not heard anything from Utah Medicaid that they're thinking of how they're going to change telehealth reimbursement, but CMS, their physician fee schedule, suggested some changes. It's not final yet, so we're still watching that because sometimes Medicaid will adopt some of that. But on a really positive note for the health centers, HRSA has released a draft telehealth scope. And one of the things that they addressed in there, and Matt, again, you addressed it, is they are allowing providers to work from home and still have that covered under the health center medical malpractice coverage through Federal Tort Claims Act. And one of the things that kind of surprised me here, I mean, it's not a legal or regulatory, but it's a very real barrier, is that ability to work from home, that telehealth access, a day or two a week, is also a workforce issue. We have providers that, hey, if I go work for, so-and-so, I can work from home. People don't like to commute near as much as we thought they did. Let's see. We're also looking at the HIPAA flexibilities. Those were super helpful in the beginning, but all the health centers are using HIPAA compliant telehealth platforms. We still will rely on UTN and RTRC to look for more information about any future legal and regulatory barriers and to help coordinate a voice about what to do. I was thinking about ethical barriers, and it's kind of an unusual, I don't know, maybe not. The primary ethical barrier we thought about was inequitable access to broadband. I know Anthony talked about at the NRTRC meeting, a lot of the work that they did to try to get as much broadband access, but across Utah, there are populations where that's been a real struggle, and we really appreciate UTN's efforts over the years getting that broadband access out, and you're still working on it. So, financial barriers, again, payer parity, what happens after the public health emergency ends. We found UTN, again, a good place where we've talked about payer parity, and we've had even payers come and kind of talk a little bit about what their thoughts are, which is just good to know. The other barrier that we face, and I think Zoe talked about a little, are uninsured. At the health centers, about half the patients are uninsured. So we're trying to find ways to get as much care to people as possible with the funding that they have. One of the things we're excited about is UTN's work with the school-based telehealth as a way to create some access for Utah children in underserved communities. Medical barriers. We're finding at the health centers that telehealth really seems to be best suited for behavioral health and substance use disorder visits, especially kind of the ongoing follow-up. There's some challenges with medical care, for example, immunizations and health screenings. You can't do them over the phone. Remote patient monitoring equipment, again, we've had mixed experiences with it, but you can see for a very targeted use, for like the white coat hypertension, it can be incredibly effective. Let's see, technological barriers. We also tried to get one telehealth platform in place, and we really appreciated UTN's efforts in looking at the Visual product. I will say from conversations with the health centers over the years, it is a painful process to find one that everybody likes. It's a painful process to change. I mean, it is what it is. But we appreciate UTN kind of being that lookout on the horizon for us. Are there new technologies, new trends, policy changes? And we appreciate our past association because, again, the broadband access expansion is so important. And we look forward to the future working with UTN.
I think we can open up to questions. I have one question for you, Jennifer. On the program with Green River Medical Center and sending home the kits, were they able to get any reimbursement for that service as a asynchronous telehealth? Do you know? Was there?
I don't know. I can
involved?
reach out to Green River and ask.
Okay. Because it's such a
Yeah.
valuable service, but
Yes.
if they could get reimbursed for it, even
I
if
would
it's
check with
minimal,
them.
that would be a great thing for them, sure.
Yep, I will make a note and I will get back to everyone. And I'll send the link and I'll send the answer to how were you all reimbursed or were you reimbursed? Because I think that's a great question.
And it gave me the idea that I think in the future meetings, we'll have Utah Medicaid come and give an update on what they are looking at in terms of payment. Okay.
Jennifer, that's a pilot, right, that you were talking about in Green River?
Yes.
So is it still ongoing or?
I will check with them again on that as well. The article was just published last month, so I think it's recent whenever they were doing it. I will ask.
Where was that article published?
Medical economics. But I will reach out to Tyler and get the information.
Thank you for sharing. Any other questions for Jennifer?
Thank you, Jennifer. Thank you for leading us off. I did not know what I was going to talk about. That's why I asked you to speak first, but I knew it would come to me. And the first thing that I will say is when you talk about, for instance, the truck drivers that can lose jobs and things, I I give care to 2 truck drivers currently, and it's struck me that they must be a seriously underserved group because their schedules are impossible to make healthcare appointments. If I had to rely on him coming in during the time we established, I might see him, this particular one, once a year because their schedules are just all over the place, and it was going to be very, very difficult for us to see each other in person. But as it is, we make our appointment. He times his route so that he's at, a gas station in his truck that has good Wi-Fi. And we have our appointment. And if I wanted him to have a blood pressure cuff in his truck, if I wanted him to have an entire medical kit in his truck, that would be no problem. And it just struck me that that's a interesting grant idea if you were to pair up with one of these huge trucking companies, of which Utah has, several, and just see about how telehealth can improve the health of their drivers. Seems like a great opportunity. And that thought led me to just telling you all the most inspirational moment for me at the NRTRC conference. We were listening to the breakout of all of the not all, I mean, there are so many, but the big major telehealth grants out there. And one of the first ones I have it all written down, I'd have to look, but essentially it's, do you have a great idea for connecting providers of different specialties or in different areas through telehealth to improve patient care? And I have this situation when I'm at Four Corners. If I want to hospitalize a patient, and these are some very, very sick people, hospitalization is not outside the realm of possibility every day that I work. We have to ask them to drive to an emergency room to get an assessment, where if it is decided that they will be hospitalized, they then have to drive, X number of miles to the closest hospital, which would be Provo. And so I've had 3 patients now just flat refuse to go. They just won't. Inconvenient, they're scared, whatever it is. And so I've started to work with a couple directors of hospitals, including Jordan Valley West, where I do some weekends. And then this idea came to me that what if we could do crisis screenings at Four Corners? And these crisis screenings could be for Four Corners patients, or in theory for any community member. And so I happened to be sitting next to a doc that knew the price of an EKG machine. So we started to sort of brainstorm. The whole room helped me brainstorm sort of what would be the barriers. And you go, okay, well, what happens in an emergency room that doesn't happen in an outpatient office? You rule out an MI, myocardial, a heart attack. No ER doc's going to let someone go if they're complaining of chest, all of these things. Okay, so it turns out a little EKG machine is somewhere between like $8,000 and $10,000. You can imagine a grant would pay for that. And then what else do you need? You need some lab work done. You need a UA. These things are all very, very possible in an outpatient setting. And the nurses at Four Corners, they're really experienced nurses. And so I just started to think about this as a grant idea. And then maybe you use telehealth. That crisis worker is in some ER somewhere. That crisis worker is probably not at your outpatient clinic. These are trained crisis workers, but they're sitting in many ERs throughout Utah. So then the telehealth experience becomes a communication between the outpatient office and the crisis worker and the ER doc in whatever ER you want to be in. And then it can be a direct admission without this 1, 2, 3 part process that makes so many patients in need drop off. So anyway, that's as far as I've gotten with it. I have not written anything down, but that was kind of one of my more exciting moments at NRTRC. I had not intended to listen or think about grants, but these things come to you. And then my final thought is a shameless plug. I manage a few clinicians, and in Utah, if you are a new psychiatric nurse practitioner, I can't remember what new is, might be 5 years out, and you see 30% of your patients in a rural setting, you are eligible for a $10,000 annual tax credit, which lasts 10 years. I mean, it's good money, and it's being underutilized. I suspect mostly because one, it's maybe not known about, but two, most of our providers are in urban areas, and a lot of us do not know how to access rural patients. And so I am, as a University of Utah clinician, I think if you were at IHC, it would be quite a bit easier. You know, IHC has little hubs all over the state. University of Utah really does not. And we also don't take Medicaid. But if there is anyone in rural settings that has a patient population that is not taking Medicaid and would like to do some telehealth care with, you know, a couple of my clinicians, please let me know. I'm looking for 30% of our new clinician, Dr. Sensiba's day, to be rural telehealth. So yeah. Jennifer, Eric Packer, you guys let me know. I really want to make this happen. And I think it will in some ways be the first of its kind. I don't know people like me that have their urban clinic and then they have sort of their, you know, mini rural clinic, but that's how we should all be doing it. I mean, we should all have a percentage of our patients be rural Utah. It's not that they're not out there. It's just we don't know how to access them, and we just need a little pipeline.
Well, that's the first I've ever heard of that tax credit.
Yeah, I know. That's
didn't know
another
anything
thing is
about
how do
it.
you get that out there? Yeah.
But that comes back to the whole discussion here about policy. What kind of policies? Because that's a policy that encourages providers to treat patients in rural communities.
Yep. And it was created not with telehealth in mind. In fact, I had to go to the state and get the university lawyers involved to determine, does this include telehealth? Because it was invented long before COVID. And everyone finally agreed, yes, it includes telehealth. But yeah, it should be more widely posted, certainly.
Yeah, maybe we should find out more about it.
We would have, he's from the state, from the health department. I could have the right person come in and tell us about that. In fact, there are a couple that impact telehealth to some degree.
Okay. That's great. Thank you. Any questions for Zoe or other comments? We have on the agenda right now to take a 10-minute break. Does everybody want to do a quick 10-minute break? I see some heads nodding. Okay. So what time is it? 9. So we'll start back up just after 10, maybe 10:05, if that works.
All right, everyone, shall we get back to it? Call to order. Our next agenda is a couple more advisory council member reports. Mike Foster and Stephen Salter are going to talk. Anyone volunteer to go first?
So Mike is online. Let's see if we can get Mike, or Stephen, I don't know if you want to go, since we were talking about truck driving and.
All right, so some of the things that we've been working on in Gunnison, we've had a few projects going on, but since you brought up truck driving, we have a program right now with a trucking company down there where we have helped reduce the amount of workers' comp claims. Basically using the visual hatch platform now. They were given a number to call in, they go in, they get the questionnaires and then call a provider right away. The provider then uses the telehealth to do a quick session and figure out if they need to go to the ER. With that, I believe that it was like 30% down in telehealth, and workers' comp claims for that company. So they're able to, oh, you had a twisted ankle, there's no need to go to the ER, we can treat it this way and go from there. So they've been using that platform to reduce the claims, keep the workforce working, because a lot of claims take them out of work, have to go to ER for hours, run all these tests, and then you send home with a huge bill. But now, doing this, they're able to actually prevent that, get the workforce working again, and save money for the company.
So Stephen, that's 30% a reduction in what time period?
It's been 7-8 months now, I think. Maybe a little bit longer.
So wasn't it implemented around March or April? I think it should be less than that.
I think we started it
October. It's October. Yes, 7 months.
Is it? Okay.
I think we started, I think February, we had the first couple meetings in March, so we first started pilot, and then from there it took off. So the amount of calls in the beginning were high. I mean, that we were getting 4 or 5 calls a day, easy, if not more. But now we're getting probably 1 or 2 a week. We're not as busy. This went in, so it's still working, still effective. It's still getting results, and the companies are happy with that. But we're using the visual hatch platform for telehealth. Next thing we've done is, like everyone's kind of mentioned earlier, providers are a challenge, especially in rural areas, getting services down there. So during COVID, when COVID was hot and heavy, we started the tele ICU with the U. And actually the first person that was on was my brother-in-law. He's giving me permission to talk about all this, so I can even use it for a few examples. He got COVID, was vented, was on it for 6 months. But at the hospital, we can only do so much at our hospital. So we had him there for less than 24 hours, and he wasn't getting better. So we did the tele ICU, and that worked to the point where we can get him the services he needed up north. Biggest learning thing with that was when you're garbed up in full PPE and everything else, it's kind of hard to set up a cart and get a cart into the room. So we're still trying to figure out, how to do like IC to do in fixed room units, especially in our COVID areas, because it's hard to see, hard to touch things, hard to control things when you're trying to do that. So that's something we're trying to overcome. What we've been trying to expand more on is our mental health services. Being central rural Utah, we have a high suicide rate. So we're trying to establish better services, especially for 24-hour stuff, because obviously most of the suicides aren't during the day. So we're working on expanding those. So we're trying to reach out and see what telehealth we can do. We only have so many social workers, down in this area. So it is really a challenge to find them. So telehealth, we are trying to expand our services are there. With the VA, we are working on becoming the Central Utah hub for the VA. So we already have some stuff set up, and we're going to start testing and piloting that. So like right now, if you're a patient at the VA, you have a 2.5 hour drive up here, 3 hour drive. Most of these are elderly people that can't handle the car for that long. Next is oxygen, everything else is long drives to be on oxygen. So we're working on trying to provide more services down in our area for them. But with that, we have a lot of challenges with the area. We'll use it. Yesterday, we had a flu shot clinic at the fire station. I'm a firefighter, so I was there, and most of them were elderly, and most of them didn't know how to sign up and register. They couldn't do it on their phones. They didn't know how to do it. So we were trying to walk them through on their iPads, that they had there from the health department, trying to get them registered to even do this. So it showed me that most of our community is not going to be able to use technology. So we're trying to figure out and bridge that gap and figure out how we can actually bring it to them. So I've gone iPads and MiFis, and we've done stuff like that, but who's going to be there and walk them through? Who's going to be there to show them? So that's what we're trying to figure out right now.
Gather all the grandchildren in the community.
Have one on speed dial and come next door.
Yeah, exactly.
That's the type of thing we're noticing in these rural areas is some of these people might not have internet in their home, but they don't know how to even use the technology to do these visits. So that's something we're trying to grow and expand there. Of course, we have providers that are old school that have been doing this for 25 plus years that don't want to use telehealth. Of course, you have some that are all about the bottom line dollar. How much are we getting paid for it? If I'm not getting paid, I'm not doing it. So those are the type of stuff we're trying to combat and figure out what we need to do with. And then being the IT guy, it's cybersecurity insurance renewal time. Telehealth is increasing insurance. And that is something we probably as a group need to look at to address, because big places can afford it. But it's getting to the pot where a lot of us rural places are struggling because it's getting expensive and it's getting harder. The question I just did to renew ours, I'm looking and we don't have half the resources to even do what they want. So that's something that I feel as a group maybe we need to look at and address, because it's only affecting the smaller areas, but it's going to affect the bigger places too. But are these clinics and areas actually doing cybersecurity insurance with this telehealth? Are they covered properly? Something does happen. So that's something that's just a thought I had. Not sure what else.
Okay. Those are great thoughts. When you were talking about cybersecurity, have you found that doing more telehealth is actually increasing your cybersecurity insurance, or is it that cybersecurity insurance is just increasing overall for everything?
So it's increasing more, but from last year to this year, the questionnaire never even brought up telehealth. But this year's questionnaire is: are you doing telehealth? How are you securing it? What is your ways of providing, security for this? So now they're starting to ask those questions, and I know one rural hospital that had to change insurance companies because they were denied insurance. So that's going to be an issue. And I'm not sure about the smaller clinics. I'm not sure if they're even covering themselves. So that's something that is starting to get pushed on the radar, because they are, as you see in the chart, as the visits being increased, is your infrastructure able to handle the increase?
Mm-hmm. Okay. Yeah, that's a good future topic that we could bring up for sure.
And I think, Stephen, for a lot of those questions, we can certainly provide the answers for those, as far as what they're asking you.
Let's see. I wanted to see Jolene. I can't see who's online right now. Jolene Johnson, are you still with us on the Zoom meeting?
I'm still here.
Would you talk for just a second about the fellowship, the digital navigator training? because that's been brought up a few times about how we can help individuals who may have connectivity but not be educated or trained on how to use it.
Absolutely. So in the spring of, you know what, let me just pull up some notes really quick. So in the spring of this year, we had the opportunity to apply for a digital inclusion fellowship with an organization called NTEN. NTEN stands for Nonprofit Technology Enterprise Network. They are a nonprofit out of Portland that focuses on getting people connected, especially for nonprofit entities. We applied for the fellowship. I applied under my 20% FTE under UTN, and we ended up securing that. So that was really, really exciting for us. And basically what it means is I will serve as a fellow over the next year with N10 and put out into the community a specific project that has to do with adult digital literacy. And a lot of the other fellows that I work with are fellows that work in libraries. Many of them are digital navigator for certain organizations, but there's fellows from all around the country. So there's a few in Salt Lake, a couple in Salt Lake and one in Provo. There's some in Charlotte, North Carolina, and Ohio and Oregon, all kinds of fun stuff. But my project in particular will focus on creating a digital navigator training for telehealth. And there's a few reasons why we wanted to do this. So one, digital navigator programs are popping up here and there, especially in the libraries, being that telehealth is really, really being implemented in different libraries around the country. We thought that would be a good in. But also digital navigators, basically their role is to set up people, you know, with basic digital skills. So how to obtain an email address, how to pay your bills online, things that people can do that will save them a lot of time and effort, but they just don't know how to do that. So they're connecting with people in their respective communities on these basic digital skills. And as TRCs, you know, we've created a lot of patient tools, patient checklists, you know, different videos on what to expect from a telehealth visit and things like that. But the thought occurred to me that, you know, if people who could really benefit from telehealth don't have basic digital skills anyways, why would they be looking for these tools? They wouldn't really know what a TRC is per se either, because generally we work with administrators and providers. So that's kind of the reasoning behind that. But a lot of what they've discussed in our training for the digital fellowship, the Digital Inclusion Fellowship, is ways to partner with community partners to get training out there. Community partners really, really seem to be key in all that we do. That goes for our own education at the NRTRC, you know, just being able to link up with those partners who are working in telehealth in these different states really, really pushes that education out and gives us the enrollment numbers and the response to the education that we were hoping for. So I'm working with a few different partners. I mean, obviously libraries in Salt Lake County. There aren't any telehealth access points in Salt Lake County. My initial thought was to help support maybe a telehealth space being set up in Salt Lake County, but nobody really seemed interested, unfortunately. It just seemed to be outside of everyone's scope as of right now. So unfortunately, we weren't able to do that. But that being said, I think, you know, it'll still be helpful for these digital navigators at these libraries to have this layer of training. We'll also be working with the International Rescue Committee of Salt Lake and Catholic Community Services of Salt Lake. They see a lot of the refugee population come in who, you know, could really benefit from building some of those digital skills. And they have digital navigators at their respective organizations as well. So that's kind of what we're looking at. But definitely, garnering those relationships with community partners, and then also, thinking outside the box in terms of, how people can get this training and get acquainted with telehealth. I think I heard Zoe say earlier that, reach out to all the grandkids in the area and help them, get their parents, their grandparents online. I mean, that's exactly what we're talking about. You have to kind of be creative in terms of how you get this out there. One of the other thoughts we had too was the telehealth finder tool, and just creating a magnet for people to have as like swag, particularly people who would be patients, so that they know what facilities in the state of Utah or throughout the region are providing telehealth, because we think that would be helpful to have as well. We actually might be partnering with the library mobile bus to distribute some of those in the Four Corners area. So yeah, just lots of interesting things and stuff there. If anyone wants to talk more about the fellowship or some of the things that I'm learning and implementing, you feel free to reach out to me at any time. It's a really exciting project and definitely worthwhile.
I'm surprised to hear that libraries, even Salt Lake Library, that has so embraced, novel roles of librarians with their care of, care of homeless population and handing out naloxone kits. I am surprised to hear that they weren't on board for this.
Yeah, and I mean the main factor is cost, right? So there is a pretty big cost associated with implementing like pods in general. I mean, if people are going to do telehealth in libraries, they definitely need kind of a HIPAA compliant space, and they just don't have a whole lot of space for it. At least they don't think. So I mean, it's hard because I do have a certain amount of funds for the fellowship, but nothing that would go to covering the cost of one of those. Then you talk about maintenance and training the librarians. I know that at the NRTRC conference, when we discussed libraries, they talked about training them in suicide de-escalation, because that is a problem that could come up. So the digital navigator training will be, I think, really, really well focused to bring up some of those concerns that people might have. And then also talk about what resources are available for patients and for people trying to navigate others through the telehealth system. So,
Jolene, have you reached out to the health sciences library at the University of Utah?
Yes. I actually just met with George earlier this week. He is awesome. He was actually at our conference and we got to connect there as well. But he had a really great networking opportunity and ended up connecting with a whole bunch of other people there. George is, for other people, he's a part of the health science library at the U. He has received a grant from NIH to develop telehealth training for libraries, which is amazing. And, I just kind of met with him and told him our projects are really different, but similar in a lot of ways. And I told him, we're not the experts on everything, and we love to be able to disseminate if at all possible. So we're kind of going to keep in touch as far as what we might be doing. A lot of the ideas that I have as far as the outline for this digital navigator training, I actually got from him and what he had set up, because what he's going to develop is going to be amazing. So yeah.
Well, and also because they are, and I just looked up what it's called exactly. They are the Regional Medical Library for the Mid-Continental region and the National Network of Libraries of Medicine. And so they have a lot of funding to also reach out to local libraries. And so I'm wondering even if they could help support some of that work that the local libraries say they don't have the money for.
Yeah, that's a good question. I'll have to touch bases with him on that a little bit more. I had meetings with a lot of different library entities. I was surprised at how many there are in the state of Utah, actually, because you've got the Utah State Libraries, you've got Salt Lake City Libraries, you've got Salt Lake County Libraries. I had no idea. So yeah, I've been meeting with all of them, and like I said, like they weren't super gung ho about setting up a space. That being said, I think if that is something that George is interested in the future, that is something that we definitely want to help navigate. So
Another place that actually would be maybe a great possibility is Fit to Recover. FTR is the gym downtown that was developed for people in recovery, right? And FTR already has a room mic'd because if you're an FTR member, you can use it for podcasts. You can record yourself. They have a recording studio, and they're always looking for novel, interesting things. And they already have that private room.
Yeah.
Just, I think gets used, but not used a lot.
Yeah. And if anything, I mean, to be able to maybe train some of them on the digital navigator telehealth training would be awesome. That's a great idea. And I'm going to write it down in my project plan. Thank you so much.
Thank you.
Jolene, may I ask a question?
Absolutely.
This is Jennifer. I was just curious when I was listening to the session at the NRTRC on this, they mentioned the librarians were concerned about their liability for what if something happened, all that sort of thing. Did you get that as well, or was their primary concern the lack of funding?
Absolutely. I think that's a big concern. There's a certain amount of training that I think needs to go into this. And that's one of the things that George from the health science libraries is addressing in his training, because it comes up more and more as we have people doing these spaces. Like I said, there's been some programs that have done some de-escalation of suicide training. It might behoove them to also get certified in CPR in case there is a medical emergency of some kind, different things like that. So he's going to have a whole section on ethical concerns, which I think is really, really important because it is coming up more and more. But yeah, so that's something that I'm hoping to include in mine as well.
Thanks.
Yep. Anything else?
Okay, thank you. Okay, and so we're going to now dive into the.
We're gonna go to Mike.
Oh, yes, I'm sorry, Mike. Mike, are you there with us? All right, there you are with the beautiful ocean setting, sun in the background. It's gorgeous where you are.
I'm sorry. Hopefully they're quiet outside for just a minute. They're doing construction just outside of my office. Can you hear me?
Yes, we can.
Okay. So going back to what Stephen was saying, yeah, we're struggling with cyber insurance also around telehealth. Just this past week, I've gotten a lot of requests from our cyber insurance company just around the requests for the vulnerability scanning they're doing on the visual sites regarding our services we're providing, which is a little frustrating because their scans are so basic. It doesn't seem like they know exactly what they're doing. But it was interesting.
Sorry, Mike. Can I just stop you there for a second? When you say they, who are you referring to?
AJG is the company that is asking for these. That's providing me with these reports, asking me to address these questions around their scanning. They've hired a third party to do some scanning around our websites and our email. And some of the scanning comes back to like telehealth.mrhmoab.org, which is a visual site.
Right. Okay. So if you want to share those with us, we could probably help you out in relation to like answering those questions.
Our partner Arctic Wolf was very good at answering those.
Okay.
and the report they wrote up for me was tremendous.
Okay.
Basically shutting down their concerns.
Okay, so it actually brought up an issue when you put it in the chat, which I've responded in chat as well. But for the benefit of everybody else listening, we don't actively scan the visual infrastructure, which is hosted on AWS today. And it's probably something that we ought to put in place. So we ought to scan the infrastructure on a weekly basis. But in order to do that effectively, we sort of need to work with Visual to determine what the range of IPs are that are used for delivering all the services for our UTN customers. So I guess that's something we can probably put in place.
And right now we're in the middle of implementing Meditech, a new EMR. And my informatics team is very excited about the telehealth offerings around the patient portal. And they've started investigating grants around exactly what we've talked about here, is the take-home healthcare options with blood pressure and things like that for providing the patients the equipment to take home. It's a little more than they can do right now with the implementation of the software and the training, but they're looking forward to that next year. So there's some good information to take back from this meeting.
So are you talking about Meditech having an offering where you can take these take-home devices and plug the whatever it is that they're monitoring directly into the patient's record?
Yeah, it integrates through the patient portal.
Right.
And into the chart.
Okay.
Mike, did you have more? I'd love to hear more about what you're doing on the substance use and mental health side.
Well, we just had we opened our Moab Regional Recovery Clinic this year. That was the first phase of our addition and remodel to open. And Dr. Lauren Press started that. She just left and was replaced by Dr. Cook. And the telehealth has been a real big piece to that, because we've seen the patients liking the anonymity of not having to come in and being seen going into that facility. But yeah, the addiction medicine, behavioral health, being able to visit the nurse or the provider. One of the things we've seen is the technical component of that, and people using aging devices, older cellular devices that really don't perform with any of these platforms, Visual included, even on 4 and 5G cellular networks. But we looked at our reporting to see where we were using the Visual service, and we were surprised to see how much of it we were doing in the behavioral health arena. We thought it was more in our family practice, and it's the majority of it is in the behavioral health area.
So, Mike, when I was talking about that idea about having, a virtual ER visit, it was because of my conversations first with Dr. Press, then with Dr. Cook, in alliance with Dr. Wark, who's my medical director at Jordan Valley West. And so right now, Four Corners only sends to, maybe 2, max 3 hospitals, and they're so often booked. And Dr. Wark and I would love to get patients seen at Jordan Valley West. We're the preferred Medicaid provider for the state. But we don't have a contract or whatever it is. And then it was, patients having to drive into Castleview, et cetera. But this is a conversation that continues to go on between Paula, Heather, and myself now that Lauren is gone. And I really think we can make it happen if we can also get your support, I think that it's just a matter of having a couple more people involved and we can open up yet another hospital for the Price area.
I would love to work with you on that.
Okay.
The next phase of our remodel is an expansion of our emergency room.
Oh, cool.
And so we are
So a
building-
telehealth pod in there maybe, huh?
We've been doing telehealth, telestroke mainly in our
Yeah.
emergency room, but we do have a room in there, especially for psych in our ER.
And it's telehealth capable. So a crisis worker and a patient could be connected with, say, like me, a psych provider somewhere. We could all be in a room together virtually or physically.
Yes.
Yeah. Yeah. That's the wave, definitely. The process for getting someone admitted to a psychiatric hospital has been antiquated for a very long time. And there's just too much opportunity to change that with this. We have to do it.
Mike, anything else you wanted to share?
I don't have anything else. Thank you.
Okay, any questions for Mike? All right, I want to thank Zoe and Jennifer and Mike and Stephen for sharing, coming prepared to talk about this. But I also want to open it up. Is there anyone else that has lessons learned through the pandemic, barriers to the adoption of telehealth, either clinically or technologically, that they want to bring up or share at this time?
So I just want to say the biggest thing I'm running into, Mike probably seeing too, is finding the right equipment for the rural areas. You know, yeah, you might have connectivity and stuff, as you brought up. There's just some of this equipment's way expensive. It's hard to get our hands on. I mean, right now, our switch is back in February, and I still haven't received them. So how am I going to get telehealth equipment going in timely manner for projects? But as we move more and more, I feel telehealth is more going to stay and is going to keep growing. We got to figure out ways to kind of supplement some of those devices for the hospital and everything else. But and like right now, I'm not sure about Mike. I have 2 telehealth carts at my hospital. They bounce around a lot. I mean, stroke, ICU, burn, crisis. You know, it's always going. So, I mean, one day we might have those carts going to 4 or 5 different rooms. So and the cart's $60,000. You know, it's not cheap just to grab and place with. So it's something to think of. You know, grants, and I've been trying to write grants. I got that COVID-19 telehealth grant. You know, I went to the grant writing workshop. You know, problem is there's not a lot of grants out there that focus on IT. A lot of it is I might be able to throw an IT piece into it, but it's not the focus. And as we grow these programs, IT is built right into it. So we got to kind of find a way to, I feel, fix that gap. Sorry, that's just an IT guy's opinion.
I work really closely with the Erie side of the house. You can, and I asked Cisco the other day, what are we looking like for this upcoming year? And I said,
Marjorie, give him the mic.
so they said no change, and we're still looking at horrendous backhauls on things. So I think we got another year of it anyway.
So Stephen, it really depends on what exactly you ordered, because those lead times do fluctuate a lot. Like we had lead times that went from January 3rd to stuff being delivered in July of this year. You know, so it really depends. And if we can help, you know.
Is any of this stuff US made or?
Parts of it.
Yes, yeah, yes and no. Could be US assembled using parts that are sourced from all over the supply chain.
It's chips coming out of Taiwan.
Yeah, sure.
That's the problem.
That power supplies.
And
it's just weird what the pandemic did to some of this stuff. I mean, you're looking at some things, chips, power supplies, to just the fact of there's such a high demand, there's just not enough of them made.
Yeah, of course, right?
Everyone pivoted to this in a few months.
Yeah, demand surged over supply, I'm sure.
And the squeaky wheel gets the oil, so be loud.
So Matt, shall we go on now to our discussion of purpose D? Identify, I'm not on. Yes, is that what we're doing now?
Yeah.
Okay. So next we're going to, if you will go to your, what are these? These are, this is the advisory council mission.
Yeah.
And
Purpose of the advisory council.
Yes, thank you. On the second page of our agenda. So you'll see that D again is identify, address, and seek to resolve the legal, ethical, regulatory, financial, medical, and technological issues that may serve as barriers to telehealth service. So Matt will start us off, but hopeful to have this be a roundtable.
Yeah, so I've been taking notes. Tim, can I share my screen? I think I've got it set up this time that it should work well.
It shows your notes.
Yeah, because there we go. This is meant to be a discussion, but I think starting off with some of the things I've already heard might help. Topics for future meetings, and also some of these barriers that we've been talking about. So talking about telehealth access points in libraries and other public spaces, like you said, is really kind of a wave. I think it's coming. It's going to be a major part of how people access care.
Because you guarantee it's already been done in other countries. Yeah, this of course is how a lot of communities work already.
So, and kind of tied to that is reimbursement for remote patient monitoring, asynchronous telehealth. Asynchronous telehealth is listed in the definition of telehealth in the state code, but reimbursement's not quite there to make that easy for clinics and hospitals to do and get reimbursed. So in general, the future payment for telehealth services, so we can ask payers to come and join us again and talk about their plans for how they will reimburse for telehealth services, especially once the PHE ends, as well as Medicaid, having them come and talk about payment. I'd love to continue to learn more, Zoe, about your tax credit and getting providers to serve rural communities, connecting you with facilities that need it. We'll continue to give updates on the digital navigator training. And then I think this cybersecurity one is a big one, understanding how offering telehealth services may be impacting your cybersecurity and things we can do to try to lessen that. So those are some of the things I wrote down. I think I'd just really open it up and see if there's other thoughts or topics that you, as an advisory council, would think we can focus on over the next year at least.
I like hearing periodic. I like hearing the periodic updates on the broadband. Like, I think it's such an important issue for Utah, and you guys have, it's kind of one of those, like, we've done it sort of things, but we still need it, and we like to hear about it.
And talking about broadband, are you talking more about the UETN network and what we're doing, or getting access to homes? Or both? UETN, okay.
But boy, Anthony just showed Linda and myself his video. He takes all of the, what are those flying cameras called?
Drones.
Thank you. I'll do drone video, and his footage of them laying this 200 miles of line where it takes, you have to bore in, because it's just rock. You have to bore in, you know, with a big scraper guy, and then they have to pull out the rocks, and 200 miles, and you're watching this going, they must go, you know, a couple thousand feet a day at most. It is so laborious.
Which is why it's so expensive.
Yeah, you can see why. I mean, to get those, you know, those big machine drivers out there, these are specialists. They probably don't live in the area. So now that you know, they're literally living, you know, in these rural communities to do this 200 miles of line. I mean, it's really quite a story that's unfolding.
If you ever just bored, Google like how to get to Navajo Mountain, you have to go down into Arizona and around. I mean, it is a incredibly remote, but it's important to the Navajo people. So they have a clinic out there. I mean, it's very, yeah,
It's
remote
important.
doesn't even quite,
No.
it goes beyond remote.
Yeah.
So.
The occasional update on satellite coverage, you know, what's happening with Starlink and what is the world's commitment to giving access to people, because of course, for every Navajo mountain we have, someone has a jungle, you know, deep somewhere that people live. So, I mean, there has to be a global commitment to this, and where does the world stand on their interest and their financial incentive.
Yeah. And again, where I'm at, we're not as bad as they are, but there's still spots in our community where, being where we're at, we service multiple small towns in our area, and literally you go in the house, you have no cell service. You come outside, you have one bar. And then because it's a small telephone company that does the internet, they're trying to beam things everywhere, and it's not reliable and everything else. So, I mean, we still have coverage issues there, you know, and of course I'm like theirs, but still, I mean, but I've talked to the cell companies, being a firefighter and EMT, you know, we deal with radio issues and phone issues all the time on wildfires. And it's like, we got to find a way to fix this. But you know what they told us? There's no population there. I'm not making money, so why should I fix it? And I mean, that's kind of the attitude. So if you live rural, it's not my fault, it's your fault. Why should I provide coverage for you? And I've gotten that calling some of these companies trying to figure out ways to boost signals. So Wayne County has 2 cell towers in the entire county. So Capitol Reef and a couple other vacation spots have no cell service because there's no coverage.
Yeah. Well, until the world decides that access to internet is the same as access to clean water and, you know, all of the other basic needs, which you could argue we are there, until the world decides that that is something we will invest in globally, it's, you know, it's just going to be this uphill battle. So hopefully there are people at a very high level saying this is a basic need and we need to treat it as such.
I don't remember which session I was in, but somebody said the thing that access to broadband or lack of it was a social determinant of health. And that really struck me, because I think now it's so true. During the pandemic, it meant whether a child could keep up with their education or not. For an elderly person, it might be, you know, a really important connectivity. I mean,
yeah, you can certainly start to view it that way. And I think there is a Z code. If you can encourage providers to consistently use that Z code that basically boils down to lack of access to care, which in this day and age that would be, you know, if we can start generating that in medical bills, you could make an argument for it.
Another argument, simple, is gas prices. All elderly have fixed incomes as it is. A lot of them I talk to love to drive up north once a month or whatever for their doctor's appointments, and now can't afford it. So, I mean, that's the next thing with the world going to where they are. They're not going to be able to afford to drive up the 2 hours for their doctor's appointments. So that's another reason why I feel, especially in rural areas, telehealth is going to be a growing thing. Yes.
Yeah. So I added that topic as update on broadband, the UETN network and satellite coverage. We are doing a pilot project right now with Starlink, so at a future meeting, we can give an update on.
Is Elon gonna come talk to us?
That's Mars's job to get that.
Mars, you must be friendly with Elon.
I wouldn't use that to describe how I feel
Your
about
feelings
Starlink
about,
right now.
oh, really?
Yes, Starlink has been quite a disappointment at this point. It's way oversubscribed. It's not delivering on the speeds that
they promised,
and there certainly seems to be no benefit or no priority for a business grade service over a residential service. And we have some other technical issues that they are yet to resolve as well, because we're actually looking to pilot Starlink at Kane County Hospital in Kanab as a potential backup to their fiber service. You know, so if it works, because we can technically get USAC funding for the service, how we do it is another mystery, which I don't know if we'll actually be able to resolve. But you know, on paper, it seems like it would be feasible, but right now we've got some basic technical issues with it, which Starlink as an organization don't seem to want to respond to. And they have this new model deployed for providing any sort of support, where you basically just go and engage with them using the texting message through their website. There's no phone number to call. There's nobody to call. You just you open a ticket and you ask a question, and then maybe a few hours later you might get a response.
No, that is.
And I've left some very choice tickets for them, and it doesn't move them. So my next step was I was looking at tweeting Elon directly. And maybe, but I don't think anything's going to shame that guy, because, you know, I mean, we've seen what he does with Twitter and everything else. So I don't know if it's just some toy project for him, and how seriously, you know, they would actually look at least the business grade offering of this platform.
Yeah. And are there any businesses in Utah that use Starlink? Or lots.
There are.
Okay, lots.
And in fact, there are lots of residential customers
that are using Starlink
in Utah that are using it. So many that if you tried to go on their website today and request a Starlink residential service, you'll be put on the waiting list, because it's oversubscribed in this part of the world.
Interesting.
How did we hear about them, out of curiosity? Did an RFP go out, or?
No, we obviously keep up with what's going on in the world of technology. We heard about them when they were originally looking to launch the platform, and back in April or May of this year, we were looking at, you know, potential ways to provide additional backup for some of our sites where there's only a single telco that, you know, carries services in that part of Utah. And Kanab is one of those areas where South Central is the only player there. And so, you know, there's really only two ways today that we could potentially get them a backup solution. One is Starlink. The other would be to build a microwave path. Building a microwave path is far more expensive than deploying something like Starlink. So we decided, well, we'll have a look at Starlink. We ordered a regular Starlink service back in April or May. It got delivered to Kanab. And then we quickly found out that the tax that they applied to the sale and ongoing cost of Starlink was not refundable, because it was a residential service. At that point, they didn't have a business grade service. So they told us that it was coming by the end of Q2, I think it was back then. So it should have been the end of June. It ended up showing up in July. So we did a return on the residential service. We ordered the business service. It got delivered sometime in July. We actually have it set up on the roof of this building. And, you know, we recently encountered another technical issue, which is basically a showstopper for us. It's a really basic issue, and it's something that they say they do support, but in fact, we've come to find out they don't support it in the way they said they do. So So we have to get through that issue first before we can look at moving the system down to Canab to evaluate it. If we can get through this one technical issue we have, we think it'll work, even if it doesn't provide the sort of bandwidth that they say they can provide. I mean, even if it only provides 100 megabits per second instead of 350 that they've quoted for the business service, it's still usable for the healthcare customers as a backup, you know, when their fiber service goes down.
We'll keep you updated on
Maybe we just make our
our
own
test with it.
The UTN satellite.
It's been done.
Yeah.
So just so you understand this, the system that that Starlink is deploying uses thousands of satellite placed in a low orbit around the Earth. And when I say thousands, when they are finished with the project, they have all the satellites up there that they're expecting to have, they'll have in excess of 40,000 satellites deployed in low orbit. And I actually distributed an article in one of our staff calls where astronomers are very, very upset about what they're doing, you know, to their view of the galaxy, you know, and
40,000 right there. I mean, when you see Starlink go by, it looks like you could reach up and grab it.
right. So they have, I've forgotten how many they have. I think they have about 20,000 satellites right now in orbit.
So when you see Starlink do its weird little thing, it looks like it might be 50, but that's actually.
So I don't know. I haven't been
You've
able
never
to
seen
see
it?
the actual
I've seen it
satellites.
twice.
You have? Are you sure it's not the International Space Station that you see?
No, it's Starlink. We looked it up one night.
Oh.
I saw it in Moab first, and you go, what is that? And you can see it's like the game Centipede. One satellite goes out, and then the other one kind of jumps with it, and then it has a tail.
Right. Because that's how many are up there. But
yeah, but it certainly doesn't look like there are 20,000. It looks like a chain of maybe 50 or 100. But I appreciate now that that's just the human view, that it actually is many, many, many more.
right, and you know, and that's just their satellites. You know, Amazon's doing the same sort of thing.
Right.
Amazon are launching satellites as well to deliver a similar sort of service. Nowhere in terms of the volume that Starlink are doing. And then you have other commercial satellites that are going into higher orbit. I was having a conversation with someone the other day, just talking about, you know, like you look at regular rocket launches that NASA and other space agencies do, just like SpaceX does with their launches to the International Space Station. And just imagine, you know, having to launch these rockets, return them to the Earth, and avoid hitting all of these satellites that are just out there hovering. It's pretty amazing.
Yeah, it's interesting.
Okay, good discussion. Anybody online? Any thoughts or comments? Just try to always remember to give them a chance to speak and join in. Okay. Well, I think that's great. That's a good discussion and gives me a good list of things that we can bring up at future meetings. Good topics to even share and present with the legislature on what's happening right now in telehealth. Okay. So I think we're almost done. I'm gonna take a few minutes and do my director's report.
Okay.
And then we'll probably be done early.
Okay.
Let me zoom up here. I just wanted to cover a few things. You know, in putting this together, I really wanted to just make sure the advisory council is aware of how we're structured and the projects we're focusing on, our priorities right now. So I thought I'd start out with just our very simple org chart. This is not the entire UETN org chart. This is just the telehealth services UTN org chart. If you haven't met Spencer yet, I'd encourage you to talk to Spencer, our new executive director. He's the kind of guy whose door is always open and willing to hear your feedback, especially as as council members. You know, and you've heard from Nikki and Jolene in the blue here, who really run the NRTRC. And then you all know Mars, and Mars primarily works with Jan and Brian Crowther, who's also online, supporting really all the technology, the telehealth system, the school-based telehealth kits, our media and video services. And we get a lot of support from all of UETN. We're just hiring a new person, Kate Richards, who will support us with our USAC applications and forms. We get a lot of support from Rich and his team on communications and public relations with Susan. And so that's we've changed a few things over the last few years. We've moved our security and network engineers completely into the tech services department, and I think that's been a good change, giving them more support and resources. So in terms of services, just a few bullet points. Obviously, still, very focused primarily on the network itself. Getting USAC funding, filing all the appropriate forms on behalf of the member sites, putting all their circuits in place, contracts and equipment. I'll talk a little bit more in a few minutes about where we're at right now with the whole network refresh and RFP that we've been working on this year. But managed security services, as you've heard a lot today, there's a lot of talk about cybersecurity, insurance, but also cybersecurity threats and increasing vulnerabilities and the need to protect our member sites. So I just listed some of the services. This isn't all of them, but managing their firewall, their VPN remote access, anti-malware, vulnerability scanning. Troy and his team can provide advanced penetration testing, log management, among other things. So we are still really focused on those managed security services that we offer to the network sites. And then ever since COVID, we've been, offering the Visual telemedicine platform. We have 9 organizations signed up right now, still working with a few more on implementing that platform. Usage has declined. I debated sharing this chart, but actually I thought I would, because it actually lines up very well with the overall claims of telehealth in the state of Utah. Kind of at the height of the pandemic, we were doing about 2,000 telehealth visits a month on the Visual platform. So that's just the 9 organizations using it within UETN. That has steadily declined. We're about 600 a month right now. But really it's just declined in line with statewide trends of more people going back into the office, doing their visits in person. So not too worried about that. Still have plenty of licenses for organizations that want to implement. And Stephen gave a great example of a way it's being used in Gunnison with the trucking company and reducing workers' compensation claims. The school-based telehealth program, obviously dies off a lot during the summer. These 2 graphs are small. Sorry, they're so small. The one on the left basically shows the number of visits or encounters between students and nurses starting in January. It peaked, in March and April with about 350 visits, and then really died off during the summer. The chart on the right shows the number of actual measurements. So within each school telehealth kit, there's a blood pressure cuff, an otoscope camera, digital stethoscope, and thermometer. So this is the number of those measurements that are being taken by those kits. And so this map will just give you, I guess, a quick reminder of the districts that have the telehealth kits. The red stars are the districts that we've been able to get with in person and provide training for the school nurses, as well as secretaries and staff. The yellow stars have the kits, but haven't had much in-person training yet. On the school-based telehealth program, we're really focusing right now on expanding behavioral health services. And part of that is because there's two reasons. One, there's obviously a large need. Stephen mentioned that all throughout the state. I mean, I'd say in rural Utah, but I think in urban areas, the need is just as strong. But also from a state perspective, the need for expanding mental health services, for getting more providers is so big, and there's such a focus on it right now that it just makes sense to really focus on those services. So we have a few things in the works. We've had some discussions with the Huntsman Mental Health Institute, the UTech lab, who is providing behavioral health services to schools, about using the equipment that we already have in place in these districts and schools to connect to licensed behavioral health providers.
So after the idea might be after school hours, the nurse's office remains open and patients that are receiving telemental health care come into the school and utilize that technology for appointments.
Yeah, and it doesn't need to be after school hours. A lot of the ones they're doing right now are during school hours.
Oh, okay.
They're able to go down to administrative area into an office and do like a checkup visit. Sometimes it's a crisis.
Mhm.
It's critical, so it's done right there during the day.
Mhm. And during the summer, when it's not being utilized, what an amazing opportunity to use it for health screening. So you pay that same school nurse an extra stipend to come into his or her own office 3 times a summer, let's say, and hold a telehealth screening. And then you have clinicians of all sorts do screenings. Is it a depression screening, or mental health screening? Is it, all the other kind of medical screenings you can do, and you capture, the community screenings remotely with the help of this school nurse that knows all his or her equipment and money a few times a summer.
Yeah, so screenings has been brought up a few times. There's very specific state guidelines around vision screening, hearing screening, scoliosis.
The behavioral health ones are good though.
Yeah. So we're trying to understand those guidelines and how they can be followed, inside of a virtual visit. That's something that we're
My question on that is places that don't have school nurses that much.
Yeah.
Some places are short school nurses now, and those nurses are overwhelmed.
Yeah.
So what can we do to combat that? Because I know my county alone, one of them.
Yeah, that's where we really need to work with partners to bring those services in from outside the community. And the great thing is the technology is all set up to make that very easy. It's super easy right on the tablet to add what we call a clinic that sends a text message and an email right to a provider that there's a need there, either acute or a scheduled visit. So the technology will enable that. It's just finding those providers and resources to bring them into the communities. We are working with the state and the Department of Health and Human Services about finding funding for more telehealth kits to go into schools. So that was we're hoping to do that through the ARPA program. It may not be through ARPA, but it may be through another source, but that's the goal, is to get more kits out there and into the schools. we didn't mention, I didn't have Nikki or Jolene mention this, but we just, on the NRTRC side, we do continue to expand the courses that we offer. We're now up to 8 telehealth courses that are free resources that can be done online. I wanted to show this graph. Since we launched these online telehealth courses, we've had 55,000 enrollments and almost 40,000 course completions. So it's really been heavily used.
Does Linda know this?
Yeah.
She does good.
Yeah, in fact, Linda Edelman
Oh,
and her
Edelman.
group helped create some of these courses.
Linda got a grant that enabled myself to create the primary care one, and then another nurse practitioner at the college to create the what is it, long-term, what's it called?
Yeah, long-term care, connecting care through telehealth, long-term services and supports.
Yeah, yeah. So those were major labors of love, and I've never worked on something so hard in my life, I would say. And so it's really nice to hear that it's being seen.
being
I cannot
used.
tell you.
Yeah, I bet. And I think, I don't know if Nikki and Jolene are on, I think we now have somebody from every state in the country who's taken these courses.
Oh, cool.
So it's not just a regional resource, but it's being used all over. That's been exciting.
Yeah.
The NRTRC, just the newsletter itself now reaches 42,000 people. Our monthly newsletter goes to 42,000. When in 2020, it went to about 2,500 people. So that's the growth that we've seen there.
When you're ready.
Go ahead. I'm going to go on. So,
well, the security. I don't know if anyone here was at that session at NRTRC. The Vidara, is that the company in Provo? The psychologist that's developed this video analytics program where you assess for suicidality. You can assess for a lot of things, but it's AI, and they not only print out the question and answer. So let's call it a PHQ-9, a depression screening. So not only does the question show up on the screen, the person's answer shows up on the screen. And if the AI detects facial changes, tone changes, it kind of goes on and asks more questions. And then this information generates to an office that basically says, you have a high acuity person, you need to reach out to them. And one of the concerns with one of the listeners in the audience was, this is video of people talking about how suicidal they are, and there is a lot of concern about the security of recording people's very private answers. Where does that go and things? And they, of course, assured everyone that it was perfectly secure and all that. But as the AI starts to come out, that security, I think, takes on a whole new level when people are actually being recorded saying very sensitive things.
Yeah. So a quick update about the network refresh. So Mike Shipping and his team helped us with the procurement. We signed 5-year contracts with 9 different service providers. We applied for the USAC funding, and we're working on installing all of those new circuits right now. So 67 actual circuits connected to the UETN network. We have 22 satellite sites. And one trend is that we've been seeing a lot of, especially the hospitals, but others as well, looking for dual circuits for redundancy. So often it's, one circuit comes into the building from one service provider and a second from a different service provider, so that if one goes down, it fails over to the other. And then obviously testing Starlink. So this table just shows the service providers that we contracted with, the number of circuits that are part of that contract. And then I just wanted to give you an idea of the amount of funding. So for 5 years, for all of these 67 sites to be connected to the network, the total cost to the service providers is $4.5 million. Then we apply for the USAC funding, which gives us a 65% discount on that. So we end up getting just about $3 million in funding back from USAC. So over the course of 5 years, you can look at it as saving rural hospitals and clinics, health departments, about $3 million over the 5 years.
I know my bill alone went down $500-600.
Yeah. Yeah, that was a really good thing. Every site was upgraded to a 1 gig connection, and we got good pricing. We actually lowered our fees, and across the board, almost every site saw a reduction in the amount they pay every month. So we'll try to keep that up.
Take it to my CEO and say, hey, guess what?
Offset the cost of that insurance, huh?
We're saving some money.
Yeah.
Right, the way the world's been, everything's been going up, doubling, tripling in prices. So seeing a reduced bill, it's kind of a big thing.
Yeah, refreshing to see a reduction. Yeah, for sure. So our goal right now is the end of October, the end of this month. Can't believe it's already October, but to have all the new circuits installed, all the new equipment up and running, which I think is good. You know, contracts went into effect and started July 1st. So to have everything installed, and it's been an enormous effort. Dozens of people on the tech services team, all the engineers, field crew, going out and installing all of the equipment. It's just been an incredible effort to get that done. Let me pause there. Any questions about the network refresh or changes with the network itself? Okay. We share this at the board level. There's a lot of discussion about budget. We usually don't cover budget too much in the advisory council, but just a quick update. Basically, wanted to keep it very simple. You know, our state appropriation right now for telehealth services is $1.3 million. We invoice the sites about $600,000 that covers the 35% portion that we have to pay to the service providers, including our security services. So overall, our revenue is about 1.9 million. Expenses are pretty simple. This is very generalized, but salary and benefits for staff and expenses to service providers and hardware and software. This is our budget for FY23. The expenses are 1.7 million. And then the NRTRC has stayed stable with an annual budget of 325,000. And then, you know, I just listed here the things we talked about to focus on next year, especially for our advisory council meetings, presentations, and discussions to have. So any questions from anything that I covered in that report? Yeah, I think that wraps us up then.
Okay, well, thank you, Matt. Our next meeting will be completely online.
Yep.
And is Denise December
1st.
1st.
Yep.
Oh yeah, there it is. Next meeting, December 1st, same time. Anything else? Adjourn?
Yeah, I think that's it.
Yeah.
Thank you,
There are no
everybody.
last
Thanks
comments.
for those who joined virtually and those who traveled.
Yeah.
Be here in
And
person.
supported these sandwiches. You guys online are missing out on corner bakery sandwiches. It's a big loss. I'm sorry.
Okay, yeah, thanks,
Thanks.
everybody.
Bye.
Bye, everybody. Thank you.
Thank you.